So last week I was in Las Vegas for Dave Feldman's Coalition Science Conference. It was amazing with amazing speakers, and I did record a couple of the presentations, the full length. One was Dr. Bret Scher, and he did a phenomenal job talking about the brain and ketones. And if you don't know who Dr. Bret Scher is, he is the head advisor, I know I don't have his title correct, but anyway, at the Metabolic Mind. And they just do such phenomenal work with the Metabolic Mind and basically all things like brain related. So he just had a really powerful presentation, and I really, really enjoyed it. I learned a lot from it, so I wanted to share it with all you, and I hope you have a lot of takeaways from it too, and that maybe you'll share it or it will help someone else that you love or yourself. So enjoy.
Kill hate or fear or loneliness. He would kill those words. Well, I want to kill a conversation. I want to kill the conversation where someone walks into their doctor's office and says, I want to try this ketogenic diet because I heard it can help my type 2 diabetes, ulcerative colitis, PCOS, bipolar disorder, enter diagnosis here. And the doctor says, yeah, but haven't you heard? The keto diet's like the worst diet. Don't you read US News and World Report? Don't you see the internet, right? I want to kill that conversation. And I think the way we can kill that conversation is by realizing ketosis is a therapeutic medical intervention that's as strong or stronger than most of the medicines we have. It's not a diet.
Yeah!
So that's the root of my talk. When is a diet not a diet? So therapeutic nutritional ketosis is not a diet. It's a medical intervention. And I think when we can start talking this language, doctors and other healthcare professionals will start to realize we're not talking about what the US News and World Report doesn't understand. We're talking about what the medical community needs to understand. So first, my disclaimers. I don't have any relevant medical, pharmacologic, or food industry funding. I am the director of Metabolic Mind, which is a nonprofit initiative, a Bazooki group, where we're exploring education and resources at the intersection of metabolic and mental health. And I have a consultative medical practice. So this is standard medical care, right? We see it time and time again. You walk in, you get your drug, and you leave. And the future doesn't look brighter because now we're just going to more expensive injections instead of medications. And if this is the paradigm we're working from, then a diet is a diet, right? If this is your paradigm, a diet does not become a medical intervention, especially when the diet that we think is supposed to work is eat less, avoid fat, and move more, which can look like this. Who wants to eat like this? Right, a little bit of an exaggeration. But instead, when people are taught to eat like this, they end up eating like this. And then they say, okay, well, moderation. So they eat a little less. And we know that does not work. Like, if you ask any doctor, does this work? They will say no. And then you say, well, what are you doing about it? And they say, well, diets don't work. And that's where we have to change the conversation. Because diets like this, we're all here because we know diets like this work. Now, what does it mean to work? Well, that's part of the problem. It can work in so many different ways. Do you want to lose weight? Or do you want to put a chronic, seemingly irreversible medical condition into remission? And that's what can happen. So, ketogenic therapy, therapeutic nutritional ketosis. The words we use matter, right? If we use the word keto diet, that comes with so much stuff, right? Whether it's the internet, whether it's the way you're taught in medicine, a keto diet comes with baggage, I guess you could say. Not necessarily all deserved, for sure. But what about ketogenic therapy? What about therapeutic nutritional ketosis? It's more of a mouthful, but it explains more of what we're doing. We're using the physiologic state of ketosis to treat a medical condition. And if we can start framing the discussion around that, things will change. But is there evidence? Well, yeah, there's evidence. So, efficacy and safety of low-carb and very low-carbohydrate diets for type 2 diabetes remission. Systematic review and meta-analysis of published and unpublished randomized trial data. Now, that's a mouthful, but type 2 diabetes remission. So the doctors in this room know, like when you were in medical school, did you ever hear the words type 2 diabetes and remission used together? Never. Never. It's not a thing, or it wasn't a thing, I should say. Now it is. And is this a one study? No, this is a systematic review and meta-analysis of published and unpublished data. So there's more than one study. And what did they find in this 23 trials with 1,300 people? That there was a higher rate of diabetes remission. So again, diabetes remission of 57% compared to 31%. So 57% type 2 diabetes remission. And then of course our friends at Verta Health published 2-year and now 5-year data about using a ketogenic intervention. And what did they find? They found there was a resolution of diabetes, reversal in 53%, remission in 17%. The difference being whether or not there was metformin, basically. But not in the usual care group. The usual care group did not have that. But so you put these two together, and what's my math? Like 70%, right? That's pretty amazing to something that wasn't even really discussed maybe 10, 15 years prior. And no, I did not forget to put something on the slide. This is the number of studies showing 70% remission or reversal for using medications in type 2 diabetes. Here's the whole. And someone will say, well, what about GLP-1s? Aren't those starting to show benefit and remission? And the answer is no, because you're dependent on the medication. And that's the whole point, that we can treat a disease, put it into remission without being dependent on the medication. And studies are clear, when you stop the GLP-1s, you gain the weight right back. Except, since we mentioned Verta, they also did a recent study showing that if you treat those people getting off the GLP-1s with a ketogenic diet, they don't regain the weight. So, another interesting finding. But then what about other ways that ketogenic therapy, ketogenic interventions can be beneficial? And I like this slide because it shows the brain. And the brain is, here looks sort of like mystical and magical. And in a way, that's sort of how it's like in medicine. If you're not a neurologist or a psychiatrist, the brain is like its own thing out there. You don't quite understand it or want to understand it. But what we know is mental health is health. I give credit to Georgia E. because she always says, last time she checked, the brain was connected to the body. So we better start treating them like they're connected. Because mental health is health, and health is mental health. And what we know from decades of research and a century of experience is epilepsy responds well to ketosis. And epilepsy and mental illness are both in the brain. They're brain cells. And we know that there's some potential shared mechanism and there's some potential shared medications. So if one works, something works for one, it makes sense that something would work for the other. And we know the brain likes ketones. Well, what does that mean? That's sort of like a glib statement, right? To say what is anthropomorphize the brain, to say that it likes ketones. Well, let's think about it. What do we know about what happens in so many neurologic and mental health disorders? We know that the fuel usage, the fuel transformation of glucose to useful energy is impaired. We know that. That's not like a question. So how do we improve that? Well, providing ketones as a novel, or not novel, as a different source of energy, as a more efficient source of energy, makes sense. And we know it works. And research is starting to show us how and why it works. And these are other effects that ketogenic interventions can have on the brain. They can balance neurotransmitters by increasing GABA, decreasing glutamate. This is shown in patients with epilepsy. And actually, there's a study starting right now from the University of Pittsburgh with Dr. Mary Phillips, where they're looking exactly at this in patients with and without bipolar disorder to see how, if the effects are different or similar. But we know this is an effect with someone with epilepsy, so why wouldn't it be an effect? The brain is the brain, neurotransmitters are neurotransmitters. Ketogenic interventions can do that. They can decrease neuroinflammation. That's a very important finding. They can provide a more efficient brain fuel source, which I already mentioned, and they can decrease brain insulin resistance. If you're insulin resistant in the body, you better believe your brain's going to be insulin resistant as well. And there's one study that I think really deserves mentioning about brain insulin resistance. Dr. Cindy Calkin did a study where she treated patients with treatment-resistant bipolar depression with metformin, a drug that works in the liver, not the brain, works in the liver. And she found that those patients who took the metformin and reversed their insulin resistance, measured systemically, dramatically improved their symptoms of bipolar depression. Not by giving any medication that's supposed to work in the brain, but only by improving insulin resistance. So there's a pretty clear association. Improved mitochondrial energy production with ketosis, that's something we're learning a lot about now, but it's pretty clear to affect the function, the cellular function of brain cells, and it can affect the microbiome and how that relates to the brains and so many others. Now, does this sound like a diet to anybody? Do you think reducing your calories by 500 calories is going to do this?
Nope.
Do you think just simply changing, the type of carbohydrates you're eating is going to do this? No, and that's why I don't like to speak about ketosis as a diet. This is a medical intervention. Show me a drug that does all these things, and I'll show you $1 billion blockbuster. But we don't have that. We can do that by changing the way we eat. But eating better isn't enough, just like I said, right? Just decreasing your calories, trying to focus a little bit more on healthier foods doesn't have those effects. Sure, if we cut out ultra-processed foods, if we eat whole foods, we are going to dramatically improve our health. But not to the point where we are having all these effects, right? So I'm not discouraging anybody from saying, I want to cut out ultra-processed foods, I want to eat more whole foods, even if it's not a ketogenic intervention, that's fine, you're going to see benefits. But if this is your goal, there's one way to get there, and that's with ketogenic therapy. Now, studies are happening for sure, and this is an old slide actually. I really need to update this to say that there's one observational study, one case study in bipolar. Not anymore. Now we can probably add 3 more to that. And same for major depression, we can add one, and schizophrenia we can add. So this needs to be dramatically updated. But the point of this slide is, what level of evidence do we need to recommend a food-based intervention? Right? If it's a drug, you need the randomized control trial, you need the FDA approval. You also have pharmaceutical companies spending hundreds of millions, if not billions of dollars to perform those studies. But when it's a food-based intervention used as powerful as a medicine, we don't necessarily need that. What we need to balance, is it safe, is it effective, who do we do it in? And that's where it gets a little uncomfortable, right? To say ketosis is a medical intervention. Anybody can do it without clinical supervision, but that's where we have to have some caution, because are you doing it right? Are you using ketogenic therapy versus just trying a keto diet? And it's subtle, but that's something to discuss and think about. But now I want to talk about one study that was done fairly recently by Dr. Albert Denon in France, Dr. George Eade, Eric Westman, Laura Saslow, some very impressive names helped publish this. And this slide is courtesy of Dr. Adrian Sotomoda. So what Dr. Denon did was he took a collection of his patients that he had treated for years with refractory symptoms that he was not able to control after years of medical therapy. He put them in the hospital, and the only thing he did was change their diet. And so he put them on a ketogenic diet, which really was ketogenic medical therapy. And you can see the results were very impressive, with 100% improved their symptoms, 43 clinical remission. And again, if you talk to psychiatrists who've been doing this for decades and say, what's the likelihood of achieving clinical remission for refractory mental illness, they would probably just scoff and say, no, it doesn't happen. We had this, 43% of them did it with a ketogenic intervention. And you can see they also lost weight, they reduced their medications. But I want to draw attention to some of the specifics. So the Hamilton Depression Rating Scale. Okay, so that's just what psychiatrists can use to measure the symptoms of depression. And keep an eye on these numbers, from 25 down to 7. Okay, and the Positive and Negative Syndrome Scale, PANSS, from 91 to 49. What does all that mean? Well, we're going to get into that. Okay, so here's what, this is the Hamilton. 23 is severe depression, 7 is normal. Remember, it went from like 22 to 7? That's pretty impressive just based on that. But how does this compare to other studies? So this was a study looking at nortriptyline. I apologize, it's a little complicated. But nortriptyline was, I guess, one of the first sort of antidepressants that was approved for use. Well, not one of the first, but one of the first sort of mainstream, very well accepted antidepressants. And what they found, if you look at, what am I looking at here? I should know this. Okay, This was an intent to treat, and this was those who actually completed the trial. But if you look at where are they starting in? They're starting in like that 22, 23 range, similar to what they were in Dr. Danon's study. And where are they getting down to? Well, they're getting down to like the 5, 6, 7 range, similar to Dr. Danon's study. Here's an FDA-approved drug showing a change very similar to what Dr. Danon showed with ketogenic interventions. So remember, they started with 25 and got down to 7. Very similar to what was used for that FDA approval of nortriptyline. Interesting. Well, how about this? This was olanzapine, risperidone, or antipsychotic medication, so using the PANS score. And here they went from 95 to 47. Sounds oddly familiar to what they showed in Dr. Danon's study, right? Going from 91 to 49. So when we talk about ketogenic interventions having effects similar to medications, it's this kind of data that really needs to make us kind of raise our eyes a little bit. These were used for FDA approval of the medications, and yet Dr. Danon saw similar results with ketogenic interventions. Now, the caveat being, it's not the same population, it's not the same time frame, right? This isn't exactly accurate science to say it's the same. We need more studies done in a way that those studies were done, randomized controlled trials, etc. But you gotta start somewhere, right? You have to start somewhere. That's how science progresses. And this is what we need people to take note of, to say, this is a therapeutic grade intervention that is likely similar to medications. So therapeutic nutritional ketosis is not a diet. How many times have I said that? Anybody keep track? But I'm going to keep saying it because this is the way we need to reframe the discussion. And ketogenic therapy is not trying a keto diet. Now here's where I guess it could come off being almost a little arrogant. If someone says, I tried a keto diet, it didn't work, I say, oh yeah, well you didn't do it right. And that sounds terrible, right? But in a way, you sort of ask yourself, well, did you do it right? Were you measuring your ketones? Were you doing it under clinical supervision? Did you try it for at least like 6, 8, 10, 12 weeks, depending on what you're trying to treat? Were you targeting a specific ketone level? Or did you just start eating a bunch of bacon and think that you did keto therapy? And sometimes people confuse that, right? Like at Metabolic Mind, we put out so many YouTube videos to try and help educate people, and we get responses like that. I tried a keto diet, it didn't work for me. And I always want to dig and say, tell me more. Tell me what you did. Tell me what didn't work. Tell me what work means, right? We have all these different questions, and those are the questions that are answered with ketogenic therapy. Those are the questions that are asked and answered with ketogenic therapy when you're working with a trained professional. Now that's the other caveat, a trained professional. I wasn't a trained professional 20 years ago when I exited my fellowship. No way, I knew nothing about this. And that's what the majority of doctors are in. So this is where we need to help provide the education, to put it out there so people understand this is a therapeutic intervention and not simply eating a bunch of bacon. Because that's unfortunately a big part of the perception. And as with any medical intervention, we have to think about, well, is it completely safe? Are there any adverse effects, additional effects that maybe we wouldn't expect? So sleep. Sleep is a big part of this, right? A lot of people can report changes in their sleep when they started ketogenic therapy. Now, if that happens to be someone with bipolar disorder, who may be prone to mania, that's pretty important to recognize, right? And that's why it can be a little concerning for people to try this on their own. And we have a whole video at Metabolic Mind about this, about how do you diagnose, prevent, treat hypomania, mania when starting ketogenic therapy, because it's a real thing, right? And what about the keto flu? Right? We all know about the keto flu. There are some simple ways to try and prevent it: increase hydration, electrolytes, maybe transitioning a little more slowly. But if you're prone to depression and all of a sudden you're feeling lethargic and decreased energy and a little more moody from the keto flu, you're going to say, I'm not doing this. This is making me worse. So that's the other problem. If someone says, I tried keto and it didn't work. Well, if that was the case, if you didn't make it past the first week because of the keto flu, you didn't try ketogenic therapy, right? So we need to be aware of that. Medication levels. Turns out, ketosis is a powerful physiologic intervention that can change the levels of many medications, including psychoactive medications like valproic acid, like lithium. It can affect the levels of the medication, which could be a good thing. It could sort of help you taper off them as long as you're doing well. If you have increased symptoms, then it could be sort of an unwarranted or an unwanted taper if it happens too fast, too soon. People need to be aware of that. We have unfortunately seen cases of someone who says, I went on a keto diet and stopped all my medications and I felt terrible. Well, yeah, you've been on these psychoactive medications for years and years and years and thought you could just stop them all at once. So we have to be careful about that. And that's where this whole concept of ketogenic therapy comes in. Just like any treatment, you're going to have to do it responsibly and carefully. And the energy levels, sort of like with the keto flu, energy levels can go up or down with ketosis. And how do you differentiate just a normal energy change versus the verge of something more concerning, right? Measuring sleep is a big way to do it, but it needs to be taken care of. And support. Now, one of my real pet peeves is when someone just says, I guess this is another conversation I want to kill, is, oh yeah, you could try a ketogenic diet, but God, it's so hard. Why would you want to do that? You would totally restrict yourself, and it's really hard to do. Well, that may be true for some people, but I want you to ask Matt Mizuki how hard it is, you know? For him, sorry if I'm speaking for you, Matt, but you know, something that changes your life like that isn't so hard. I think probably having psychosis and having mania, that's pretty hard. And compare that to just not eating bread and not eating pizza. So you have to, you really have to put this into context. So it really bothers me when someone says it's too hard to do. Now, that being said, I'll admit, it's not easy for everybody. For some people it's very easy, and for some people it isn't. And that's where this concept of support comes in. You know, another thing we hear is, yeah, I tried the keto diet and it was just too hard to do. Well, did you have anybody helping guide you to try and help you figure out which foods to eat, how to substitute different foods, how to shop, you know, how to order out? All these things make a difference. And so support is part of prescribing the ketogenic intervention responsibly. And so that's one thing we want to do at Metabolic Mind, is we want to help provide that information for people so they can understand the different concepts involved with starting ketogenic therapy, what you could expect, what you have to look for, how to talk to your doctor about this, what lab tests to get. And so thanks to the Mizuki family and Mizuki group, we have almost 100 videos now on YouTube about this. We have newsletters and we have blogs and we have links to all the other people in this field trying to elevate what is happening for using ketosis as a therapeutic intervention. So I'll say it one last time. Ketogenic therapy is a medical intervention, not a diet. And once we can change the way we talk about it, we can hopefully start to change how physicians and clinicians see that and start getting people treated with it appropriately, safely, and effectively. So thank you very much. Modified Atkins diet likely works just as well. Modified Atkins can be up to like 30% protein, so very different than that 4-to-1. So that's the beauty of ketogenic interventions, is you can test it. You can't test how compliant you are with a Mediterranean diet or a calorie reduction necessarily, because nobody really knows how to count calories. But Keto Mojo, raise your hand, Keto Mojo. You can test your ketones and you can know exactly where they're at. So some people, especially if you're metabolically less healthy, may lower their ketone levels when they get up to protein, 1.5 grams per kilogram. Other people can maintain high ketone levels despite 2 grams per kilogram. There is some variation there. So I'm a big proponent of protein. We want lean muscle mass. We want to remain, it's very important for metabolic health, very important for longevity. So I think we need to make sure we're getting adequate protein. So doing that balance of ketogenic therapy with adequate protein, I want someone to eat as much protein as they can without seeing their ketone levels drop. All right, so that's where testing your ketones can be so important, and that's part of ketogenic therapy. Not just starting a keto diet and blindly going, but testing. That's one thing I love so much about ketosis, is we can test it. Yes?
Question for you. Just be loud. I can be loud. So question for you. I feel like a lot of people in our community don't know the mental health benefits of keto. So So what can we all do? We're all here. What can we do as a community to help spread that word so people know that keto can help with their mental health?
What can we as a community do to spread the word so people know that keto can help with mental health? Go to Metabolic Mind, because I gotta say that. You know, have everybody go to Metabolic Mind. Have them read Georgia E's book. Have them read Chris Palmer's book. Have them follow Nicole Laurence on Twitter. This is a movement that is gaining so much speed and really. And you bring up a good point. You know, 2 years ago, probably nobody really knew about this, and these resources didn't exist. And again, a tremendous gratitude to the Suzuki family to now have these resources and to be able to elevate everybody else who's providing other resources. So we have to start talking about it. We have to start referring people to these sites to give people hope who are looking for something different and something better, and also for clinicians to learn more. And hopefully, coming down the road soon, we'll have more clinician training about this as well. Yes?
You require a specific ketone level to see the benefit of the diet?
Yeah, thank you, Dr. Lee. Does it require a specific ketone level to see benefit from therapeutic ketosis? And the answer is maybe. And so Dr. Ian Campbell completed a pilot study at the University of Edinburgh, and it's been presented and will be published soon. He did see an association with improved mood with higher ketone levels, up to like 2.5 or 3, I think, if I'm remembering correctly. Not that there was no benefit at lower ketone levels, but there was increased benefit as ketones increased. If you talk to Chris Palmer, he likes to shoot for around 1.5. We have an example of an individual, Lauren Kennedy, whose YouTube channel is Living Well with Schizophrenia, which I highly recommend. She lives in ketone levels of like 4, where she feels really good, and she came down to 1.5 and noticed a significant difference and started to notice some of her psychotic symptoms coming back, interestingly. So it's clear there's some individual variation, and it's probably safe to say in general a little higher is probably better, but it's very individualized. So the blanket statement would probably be, you know, if you want to shoot for something, shoot for above 1, but test how you feel. See how you feel at 3, see how you feel at 0.8. Try some MCT oil, try adding some extra fat. See if you can, you know, dial your ketone level up and down to see if it makes a difference. All right,
Thank you, Dr. Scher.
Yep.